Okay.
A very good evening and welcome everyone. I, Dr. 𝗕𝗿𝗀𝗃𝗃, on behalf of Voice of Healthcare, welcomes you all the speakers and the viewers who have joined in for today's session. On the occasion of Breast Cancer Awareness Month, Voice of Healthcare, in association with Cipla, has taken an initiative to bring together the experts and speakers for the panel discussion today, which aims to spread awareness regarding breast cancer. With this discussion, we shall also dive into understanding the signs and symptoms and how breast cancer treatment has evolved in the recent times. I would like to commence this session by introducing our eminent speakers. Dr. Harit Chaturvedi, Chairman, Max Institute of Cancer Care, Max Healthcare. Welcome, Dr. Chaturvedi.
Thank you.
Dr. Bhuvan Chugh, Consultant, Medical Oncology, Max Superspeciality Hospital, Gurgaon and Saket. Welcome, Dr. Chugh.
Thank you so much.
Dr. Devavrat Arya, Director, Medical Oncology, Max Superspeciality Hospital, Saket. Welcome, Dr. Arya.
Good evening. Thank you.
Dr. Aditi Chaturvedi, Consultant, Cancer Care, Surgical Oncology, Max Superspeciality Hospital, Saket. Welcome, Dr. Chaturvedi.
Thank you, Dr. 𝗕𝗿𝗃𝗃.
Dr. Sachin Gupta, Director, Medical Oncology and Hemato-Oncology, Max Superspeciality Hospital, Mohali. Welcome, Dr. Gupta.
Namaskar. Thank you.
Along with sharing his views, Dr. Harit Chaturvedi will also moderate this session for us. Over to you, Dr. Chaturvedi.
Thank you, Ritika, for organizing this. I think one of the simplest tools all of us have in fight on cancer is spreading awareness. We all know that there's huge delay in diagnosis in most cancers. Even though I would agree that over last 20 years we have seen a lot of shifting there, and relatively early detection has started happening, but still there's a lot more to catch up. And if we just focus on this one aspect, how to prevent, how to pick up early, how to detect cancer before it goes into stage 3 or 4, I think we'll win the big battle. So with that in focus, I think what you are doing, what Voice of Healthcare is doing, and what Cipla has created is wonderful, very important, and I hope more people will benefit from it. And as this digital material will be available for people to use, I think it should spread far and wide. So we all know that breast cancer is the most common cancer in women in India, and that is something, in fact, in the Western world is even much more than this, almost threefold higher the incidence. So looking at that, I will ask Dr. Aditi that what do you think is the reason for this high incidence and the growing incidence of breast cancer, and can we do something to prevent it, or what are the modifiable factors, if I can put it?
Yeah. So, thank you. So, breast cancer incidence, as you rightly said, has grown considerably in the last few decades, along with most cancers, but specifically breast cancer has become the most common cancer worldwide, considering the fact that it is much more common only in women. Male breast cancer is actually quite rare, and women at the most will make 50% of the population. Still, it's the most common cancer. And perhaps, although we cannot pinpoint what is the one exact cause of this increase, probably it's the lifestyle changes which have happened. The prevalence of weight gain, obesity, the prevalence of a lot of hormonal factors, um, lack of exercise. We don't know whether there are various environmental factors contributory. because of the current lifestyle, which is adopted by most people in the Western countries and increasingly so in developing countries like ours. Your question about what are the modifiable risk factors. So, as we all know, that only 10%, 5 to 10% of breast cancer is genetic or linked to hereditary or familial syndromes. 90% is sporadic in incidence. And although we cannot pinpoint what is the one cause of these cancers, there are three modifiable things which people can be aware of to reduce their risk of developing breast cancer. Number one is keeping the weight in check. Obesity is now called the second tobacco. It's become, as tobacco used to be the cause of the majority of cancers worldwide earlier, although it still has a significant role, but weight gain and obesity is a high risk feature for a variety of cancers, including breast cancer. So, keeping weight in check, especially for postmenopausal women, is known to be protective. The other thing is alcohol. Although there's no direct relation of tobacco and breast cancer, but alcohol, if people can avoid alcohol altogether or limit the consumption to 1 to 2 drinks in a week, that is known to be protective and help in reducing the risk of breast cancer. And the third modifiable risk factors is, so the hormonal factors are not completely in the woman's control, the age of onset of periods or menopause, but avoiding consumption of external hormonal supplements, prolonged use of hormonal replacement therapy or oral contraceptive pills for a very long duration of time. I think we need to be cautious about prescribing them for a long duration, although data has been a bit controversial about this, but that is a third modifiable risk factor we can take care of.
So I think we are gathering that of the risk factors, the hormonal one is something which there's a lot of controversy on that, whether about oral contraceptive usage or age of pregnancy and all these factors. But certainly diet, exercise, sedentary lifestyle, weight gain, alcohol, and these are very much something which we all can use. Anything you want to add, Dr. Bhuvan, Dr. Sachin? I will suggest if anybody wants to add something, please raise your hand and we'll be.
So I dwell deeper into the hormone replacement therapy. What we have found is it's the estrogen plus progesterone combined replacement which is a little more detrimental than the only estrogen ones, and rather the daily progesterone ones. So to give you the facts and figures, 1 in 50 women extra will develop a breast cancer if they're taking a daily estrogen and progesterone replacement. However, if you're taking only estrogen, it's 1 in 200. So I think that thing has to be kept in mind in terms of
The modern hormonal contraceptives have a combination, and that addresses this to a great extent.
So rather we are talking about hormone replacement therapy for the postmenopausal. Now what happens is generally, so because the cycle is such that first 15 days is estrogen and the second 15 days is progesterone. Generally, the pills these days are made like this, that it's an intermittent progesterone, and for that the risk is extra 1 in 70 women. So that's where it's a Lancet study which was published in 2019, and it's a good study. So just that I did point from my side.
Dr. Sachin, you wanted to add something?
Yeah, so another point, sir, which we can emphasize is the promotion of breastfeeding, which has again a protective action. So in some communities there's a fashion and some women don't like to do that. So wherever possible, breastfeeding should be done for as per long time as possible. So and of course Dr. Aditi has covered rest of the points very nicely, and a lot of things are not in our control, and organic lifestyle is one thing which we should look at. There's a lot of chemicals in the diet. The whole soil, air, water, everything is polluted because of overuse of insecticides, pesticides. So wherever possible, we should procure organic food, chemical free, grow our own food, have kitchen gardens, and of course diet, exercise, and reducing obesity. That's one of the most important things.
There was a question on the screen for a brief while. It has gone away now. It was a question from Vedantika, I think, that can breast cancer, Vedantika. So can breast cancer occur in young females as well or in teenage? So we'll keep taking the questions to encourage people to ask more. So I will request Dr. Aditi if you want to answer that question.
Yeah. So although the incidence of breast cancer increases with age, but if the question is can it occur in younger women, then yes, definitely a significant portion around of breast cancer, especially in our country, are in the younger age group, which is less than 40. In teenage per se, it will be extremely, extremely rare. I think the youngest patient we have seen was 19, and
19.
so
That is the
it's
teen.
yeah, so it is very rare in teenage per se, but yes, in the younger age group, in the late 20s, early 30s, we do see a significant, especially ours being a tertiary referral center. I think around 15 to 20% of our patients can, at some point of time, can be in the young less than 40 subgroup.
So my response to this question will be that whatever the age, if there's a symptom, there's a lump, there is a something pain or whatever, it needs assessment, and that is to be done by a triple test. That means every breast symptom after clinical evaluation must have imaging. Imaging, depending on age, in a younger age group, it may be an ultrasound breast. Above 40, it can be a mammogram breast as a baseline thing. Then add on that the other tool. For example, if you've done an ultrasound, if required, do an MR or a mammogram, depending on the situation. And if you've done a mammogram and you want to supplement, do an ultrasound of and MR if required. So whatever the age, any breast symptom, one has to do an imaging, one has to do a clinical evaluation, and then take a biopsy or a cytology depending on the situation. If you have a nipple discharge or if you have a lesion identifiable, then take a sample. Only then rest that this is not malignant or this is malignant, either ways. So that will be important. Don't get carried away because it's a mobile lump, because it's a young person, therefore it has to be a fibroadenoma. And we see this day in, day out, that people are labeled as benign without full evaluation. And then in 3 months or 6 months, it is delayed enough to move from one stage to the other stage. Dr. Devavrat, you want to add something to the current conversation?
So I think absolutely right. Unfortunately, there's no age where breast cancer cannot happen. And as Dr. Aditi was saying, clearly, since we are a referral center, we see a lot of women, not teenagers, but in their early 20s as well, and a significant number in their 30s as well, and which is also a young age for this disease, who come with breast cancer. And a lot of times, patients don't suspect the lumps to be cancerous because there's this myth that you can't have cancer at this young age. And I think the message that needs to go out is that if you have a lump or any possible symptom, then you need to go to a doctor, whatever your age may be.
Correct. So we also, in between, there was this thing that there's a family history is also relevant or important in small subset of patients. So I would request if Dr. Bhuvan wants to talk about it, that if there's a family history, which subset of people you will recommend that to go for genetic evaluation or stage or workup, and then recommend screening for these patients as high risk category.
So, family history is very important when it comes to breast cancer, and especially in today's age when we are finding younger and younger people suffering from breast cancer. So, what we generally tend to do is, if somebody, so depending upon the type of breast cancer they have, if there's a strong family history, if your mother, your sisters, your mother's, your maternal aunt, basically, they have a history of breast cancer, we generally advise the patients to undergo a genetic testing rather than the asymptomatic individual, because the chances of finding a affected gene is highest in the patient. So it's always better to advise somebody who's suffering from breast cancer to undergo a genetic testing if they have a breast cancer. If they have a gene which is affected, then it is easy to do a targeted testing of that particular gene in the entire family. So the most important point is the history of clustering of the family breast cancers, and if picking up one of the patients to do a genetic testing and then tracing it from there onwards. Who should be tested? Anybody who's a young breast cancer, anybody who's a triple negative breast cancer, and I think these are the
Bilateral
subsets.
breast cancer,
Yeah,
male breast
bilateral breast
cancer.
cancer, recurrent, multiple recurrences in the breast cancer. So all these are clinical factors which kind of suggest that there may be a germline mutation.
I will also say that as a general rule, it is important to be breast aware. So for that, every stimulus should be taken as a clue that just to be breast aware, to be familiar with your own breast, to be comfortable that at the right time go for screening or mammography, and if there's any symptom, then go to a physician for a checkup. Dr. Sachin, you want to add something on this? Yeah, Dr. Devavrat wants to add. Yes, Dr. Devavrat.
Yeah, so I think this family history and genetic testing is a very relevant topic. Now, generally, there's been this thought that perhaps Indians do not have as many mutations in the inheritable genes as we see in the West. And Dr. Harit, you are aware, we did a similar study in ovarian cancer a couple of years ago, and Max Saket was a big part of that study. And we realized that in ovarian cancer space, unlike what we saw in the West, 1 in 5 ovarian cancer women actually turned out to have some variation on that test. We've just recently completed a study in breast cancer also, and I think we will have some more data, more Indian data to actually understand the incidence of these mutations here.
There's already one study from AIMS, which is actually corroborating and suggesting that's almost the same risk factor as Western population, the mutations. Yeah. So then so in the prevention space, we have discussed what is possible. For the screening, we would say that everybody, what are recommendations for screening between 40 and 50 and 50 and 70? Dr. Aditi, you want to take that? And do you suggest some more tools before 40 which can be used?
So, screening, first of all, we must understand what do we mean by screening. Basically, screening is the test which is offered to people who are absolutely normal, who are asymptomatic, so who have no complaints whatsoever. In any case, like we discussed earlier, anyone who has a change in their breast, either a lump, pain, nipple discharge, anything, then they need to report to a specialist and get themselves evaluated as per the triple assessment mentioned. Screening, the term refers to people with no complaints whatsoever. So for people below the age of 40, there are no clear guidelines per se. What we encourage is that anyone above the age of 18-20 should get into the habit of a monthly breast self-examination. Although the data per se about it is, if I look at evidence, is it known to be protective? Does it lower the mortality? That data is not there. But in a country like ours, where we don't have population-based screening, encouraging every woman to examine her breast once a month after her periods is important, so that she's aware and she knows when there's a change and when to report to a specialist. Clinical breast examination is the other thing, that is getting checked by a specialist, be it a gynecologist, be it a surgeon, be it a family physician, someone, a nurse also, who's well versed with breast examination. Again, the data for this is varied. Every 1 to 3 years in the age group of 20 to 40, it can be offered, but we don't have very strict guidelines about it. The role of mammogram, which is a basic simple X-ray of the breast, is what is actually proven and which is there in, especially in guidelines from Western countries. There are a bunch of guidelines, varies from country to country depending on the public health policy of theirs. So, for example, in UK, as per the NICE guidelines, as per NHS, they'll be offering mammograms once in 3 years between 40 to 70. In UK, US, there are different guidelines as per different societies. As in a nutshell, if I have to say, that between the age of 40 to 50, a woman should be offered annual mammogram with an ultrasound. Mammogram alone may not be good enough because the breasts are quite dense, but yes, mammogram should be offered between 50 to 74 once a year or once in 2 years. Uh, Again, variation is there, but yes, opportunistic screening in our country should be encouraged. Mammogram is the test which is used because it gives much more objective evidence compared to an ultrasound. After the age of 74, basically, when do you terminate screening? It basically depends when the life expectancy of a woman goes down. So if someone is bedridden, then obviously you don't encourage screening in them. What is important to note is this is for people with no family history of cancer, so with an average risk. Anyone with a strong family history who's known to be who's known to have inherited a DNA mutation, for example, BRCA1, BRCA2, screening starts much earlier. From the age of 25, alternate mammograms and MRIs every six months are encouraged, along with uh, periodic clinical breast examinations. But for an average risk woman, I think 20 to 40 monthly breast self exam and above 40 annual mammogram is something which we can summarize.
Sure. Thank you. Thank you. There's a question on the screen. There are common myths around using lipstick and deodorant will cause cancer. Is it so? I think, as you have rightly put it, common myths. So these are actual myths, and there's no space for this as a causative factor for cancer. Any of my panelists want to say something? Yeah, Dr. Devavrat.
So, I probably would not comment on the lipstick part, but the deodorant part, there is some thought to say that some of these contain aluminum, and then when applied in the armpit or axilla, that is what we refer to, some of it may actually penetrate the skin and may mimic the changes that are brought about by hormones. Now, there are no good quality of studies to actually, link up all these products, including deodorant, with higher incidence of breast cancer, and therefore there's no need to panic. But I think increasingly regulations are coming in which are
Your signal is poor, I think. Yeah. I think we have lost Dr. Devavrat. So what he's saying, there are some studies which have suggested that there's a doubtful value association of deodorant with causative factors breast cancer, but the quality of studies, and there's no real evidence on that. So I would say using good quality material should do for now. There's no real recommendation to avoid deodorants or, for that matter, lipstick as a prevention for cancer in any way. Okay, I think we'll move on to the next conversation hovering around any new diagnostic tools in the space of breast cancer diagnosis, staging, for the purpose of diagnosis. I think Dr. Sachin or Dr. Aditi,
Yeah.
anyone to take that question? Yes.
So 3D mammography is one thing which is coming up, but of course it is not widely available, and it is also known as tomosynthesis. So they make a 3D reconstruction, and it gives more clarity and visibility of the any new lump is better with this.
Yeah. So
So,
it is
but
as used as a problem solving thing, 3D mammography, but it is certainly something which is on the go.
yeah,
See, other thing is that there's thermal scans and new tools have come up. But I think for now, mammography, ultrasound, and MRI for problem solving. These three are good enough imaging to solve any situation or complex situation in the breast for diagnosis purpose. So we'll come to the early detection and how this detection is done. So one, we discussed that wherever possible prevention, there are few steps. For screening, it is relevant population, we can screen them. And if there are any symptoms of any kind, we have to go in for diagnosis making. Now here I have only one point to make, and if I can have Dr. Aditi here for a minute, that for the purpose of diagnosis, we often miss lesions because sometimes these lesions get labeled on FNAC as benign or doing without any image guided sampling. So this is one point which I want to really emphasize, that these things are very dangerous because something gets labeled as non-malignant is an issue. So it's important that our sampling should be done in the right way by the right team and assessed by the right person. So Dr. Aditi, your thoughts on that? How important it is that we have a proper sampling and diagnosis, and what do you recommend for that as a procedure?
I completely agree. So, right, the quality of the triple assessment is extremely important. So, as far as pathology is concerned, like you pointed out, an FNAC can be misrepresentative in certain cases because the sample size is only very small, and it is difficult for the cytopathologist to give a very concrete evidence. So, an image guided core biopsy, if available, is the gold standard. Even for a lesion which is typically looking like a fibroadenoma clinically, relying on an FNA should not be encouraged. A image guided core biopsy whenever possible. If image guided is not possible due to lack of resources, and a palpation guided for a big lump can be still considered. But core biopsy over FNAC, definitely. Even for radiology, I think leaving just relying on an ultrasound is not good enough in certain cases, because what we've seen, especially in the younger age group with early mobile lumps, like you said, a lot of emphasis should not be laid on mobility, and lumps should not be just left behind because it's in a young woman which is mobile and clinically looking like a fibroadenoma. Sometimes the ultrasound can also, the radiologist may, because early triple negative breast cancers are also sometimes very well rounded, only one margin is irregular, it's difficult for the radiologist to comment. So the quality of the assessment by an expert breast radiologist, a mammogram if needed, and an image guided core biopsy should be encouraged for sure.
Dr. Devavrat, you want to add something that why core biopsy is important? For one is when Dr. Aditi has said that we identify this is benign and this is malignant. That is one part of it. Now, once it is malignant, do you think it is important to have a core biopsy upfront before we plan any further journey for the patient?
I think that's a very important point. So beyond establishing the diagnosis of malignancy, what we've come to understand is that not all breast cancers are similar. They don't behave similarly. And therefore, we've actually divided different breast cancers based on the expression of certain markers that the test is referred to as IHC, immunohistochemistry. And then the common markers that we look for include estrogen receptor or ER, progesterone receptor or PR, HER2/neu, and increasingly another test called Ki-67. Now, we know that the relative expression of these markers will impact the biological behavior of the disease. So we know that those tumors which are ER and PR positive and HER2/neu negative are inherently slower growing, and therefore for a limited stage disease, even if the tumor may be slightly big or even if there may be a little spread to the armpit, surgery is usually the first treatment option, unless there are other reasons to start with chemotherapy. Whereas there are certain subtypes which are ER and PR negative, HER2/neu positive, or ER, PR, and HER2/neu negative, something that we refer to as the triple negative breast cancers. Now, these are generally more aggressive tumors, and increasingly for a limited stage disease, while we acknowledge that surgery remains the backbone of treatment, for these patients, one may want to start with chemotherapy with or without targeted therapy or immunotherapy before we embark on the surgical intervention.
Sachin, you want to add something to this types of breast cancer and
Yeah. So, sir,
Devavrat
Dr.
was
Devavrat has.
highlighting that there are different types and the treatment.
So breast cancer is
Yes,
not a
Dr.
single disease. It's a very varied and heterogeneous entity. So when we say breast cancer, it's a multitude of many entities actually. So we can divide breast cancers according to the nature of the cells. It can be infiltrating ductal carcinoma. It can be lobular carcinoma, and then there can be some rare varieties, metaplastic, papillary, medullary, so which have different prognostic implications. And we can also divide breast cancer into types by the stage, the how big the tumor is, whether the lymph nodes are there or not, and as told by Dr. Arya, whether it is hormone receptor sensitive, HER receptor sensitive. So we have to acknowledge all these points into decision making whenever we treat a case of breast cancer. So we look into the stage, the extent of the disease, the nature of the disease, and the receptor positivity. And accordingly, we take a decision that whether we go for upfront surgery of this particular patient or whether we downstage by giving chemotherapy or hormonal treatment or targeted therapies. So all these things are taken into account.
So
So we
there's no
need
escape from doing a true cut biopsy. Yeah, there's no escape from doing a true cut biopsy and proper evaluation. Only then further treatment can be planned. Dr. Bhuvan, what is inflammatory breast cancer? You want to just
So,
highlight that our
yeah, so
understanding. Yeah.
basically, uh, just to take a step back, whenever we talk about cancer, the way we understand cancer is what is the name of the cancer, what is the stage of the cancer, and what is the fitness of the patient. So, in the terms of a stage of the cancer, we need to understand how big is the lump and how much has it grown. So, in the particular size of the lump, so there is a small lump, there is a slightly bigger lump, and there is this lump which is causing inflammation or causing the ducts of the breast to be totally blocked and causing inflammation in the entire breast. So it's basically a type of an advanced and that's where it is. It's in terms says that it's more aggressive as a disease, and it's causing the entire breast to become inflamed, and the entire breast is being affected by the cancer. That's about it.
Okay. And this is generally more aggressive tumor and requires we start with chemo first and so on.
So
Now I want to ask Dr. Aditi, what are the options of surgical treatment in breast cancer? And is mastectomy an essential component? And regarding the axilla, for both the things, for the primary and for the axilla, what are the options and what is the common practice?
Yeah. So the surgical options for breast cancer have really evolved over the last couple of decades. And where mastectomy, that means removal of the entire breast, was a norm earlier. Uh, right now, we are able to offer breast conservation, that is, saving the breast and only removing the tumor with a margin, a cuff of normal tissue around it for a vast majority of our patients, especially with early breast cancer. So almost, I think 60% is where we are able to offer breast conservation as of now, and that number should increase as and when we, our rates of early breast cancer increase. So it is very important to know that mastectomy, that is whole breast removal, is not the norm, and it's not necessarily safer. So a lot of people have this misconception that if you remove the entire breast, your chances of recurrence will be or close to nil, and they feel that, because initially with a cancer diagnosis everyone is scared, and they may want to take an extreme step and go for mastectomy even where conservation is possible. It is important to know that although radiation is required in almost all cases of breast conservation, so radiation therapy is needed, but along with radiation therapy, breast conservation has equivalent results compared to mastectomy. In fact, various recent studies have said that the survival outcomes are even better for a variety of reasons. So, breast conservation should be discussed until and unless there are only few contraindications, absolute contraindications to this surgery. The other thing is, as far as surgical techniques, what has changed is, one, I want to mention whole breast reconstruction. So even if mastectomy is needed, immediate whole breast reconstruction, that means creating a new artificial breast using either the patient's own tissue, own muscle or fat, or using an artificial implant, should be discussed in a large number of cases, even if mastectomy is needed. And the third thing which has changed is axilla management. So, like Dr. Harit mentioned, that earlier we used to do a complete axillary lymph node removal for all patients. In the last almost 20 plus years now, sentinel lymph node biopsy has gradually taken up. It is the standard of care for any patient whose nodes are basically lymph glands in a person's armpit. And breast cancer has the potential to spread from the breast to these lymph nodes, these glands in one's armpit. These lymph nodes need to be removed at the time of surgery, but removal of all lymph nodes is not necessary in all cases. Sentinel lymph node biopsy, that is using certain dyes, certain injections to identify the first few draining lymph nodes, the guardian lymph nodes, and sending it for testing is an option which is there and which is widely practiced now. The advantage of this doing less in the armpit is that the patient's arm movement doesn't get restricted, and the risk of the dreaded lymphedema. So lymphedema is basically swelling of the arm, which was known to be very common. Up to 50% of breast cancer patients who had undergone surgery would develop swelling of the ipsilateral arm if all lymph nodes were removed. Now, with usage of sentinel lymph node biopsy, even in certain post chemotherapy cases, the risk of lymphedema or any shoulder and arm morbidity has significantly gone down.
Okay, I think that's a very elaborate discussion, but I just want to add one thing that, or you want to add something, or a word on oncoplasty, and whether people who are present with initially large lump are they still eligible for breast conservation? Just to cover these 2 points in a couple of sentences.
Correct. Yeah, I missed that. So, oncoplasty is basically the usage of plastic surgery techniques along with the oncological or cancer surgery principles. So the advantage is that initially, when breast conservation, that is saving the breast, came in, it was tried for very small tumors, less than 2 centimeter tumors. Gradually, the indications expanded, and even larger and larger tumors were being offered breast conservation. The point of saving the breast is not to save a breast just for the sake of it. The cosmetic results, that means the look and the size, shape of the breast should resemble the opposite breast as closely as possible. And the usage of oncoplasty techniques, that means using the patient's own tissue from the same breast or nearby areas, has increased the rates of giving good quality cosmetic outcomes to our patients, and is now a routine. It's actually standard of care in all patients who are being offered breast conservation. So, and the other thing is, even tumors which are larger, I just mentioned it earlier. We can use neoadjuvant therapy. That means involve our medical oncology colleagues, give certain chemotherapy, certain systemic therapy options, certain medicines to shrink the tumor and save the breast quite safely at a later date.
Right. Thank you. Thank you. Now we go on to the systemic treatment, which is one of the big chunks of our practice. And I'll request Dr. Sachin to give an overview of systemic treatment, and then we'll go into specific details one by one. So generally, I
Yeah.
would want you to give us an overview in terms of chemotherapy, hormone therapy, and options of immuno and other factors, and then we'll talk about each one in detail separately.
Thank
Dr.
you.
Sachin.
So, as we discussed, that breast cancer is not a single entity. Breast cancer is of various types, and the nature of disease varies a lot. The tumor size, the nodal involvement, and whether the hormone receptor positivity is there or the targeted this receptors are there or not. So, namely HER2 receptor. And so we have many options for breast cancer patients. And breast cancer is a systemic disease. So we don't call it a local disease, we call it a systemic disease because there are a lot of chances of this disease getting spread to other organs. So we always try to cover the whole body with the treatment so that the chances of recurrence decrease. Or if the patient is already in advanced stage and the metastasis has happened, then this systemic treatment is the main treatment for breast cancer patients. So the treatment can be mainly divided into chemotherapy, hormonal therapy, targeted therapy, and immunotherapies. So chemotherapy, basically these are drugs which kill cancer cells, and these attack on the cell cycle. And but in the process of attacking cancer cells, the chemotherapy drugs can attack the uh, normal cells also. And so do we have side effects of chemotherapy. But most of breast cancer patient may require chemotherapy depending again upon their stage and nature of the disease. And hormonal treatments are easier. So hormonal therapies are available, and these are mainly in the tablet form, and some injections are also available. And usually hormonal treatments are given after, let's say, surgery has been done, and for 5 to 10 years we are giving these tablets to these patients. And so these are well tolerated and the side effects are minimal. And so there are some patients who may only require hormonal therapy and no chemotherapy, especially if their stage is early and the size of the lump is small and the hormone receptor positivity is high. So these patients may do away only with hormonal therapy after their surgeries. And then we have targeted therapies. So namely, we have an injection called as trastuzumab, and some similar injections are also available. And so these treatments are given when patient has HER2 new receptor positivity on their cancer cells. So we always test our patients for these receptors, and if we find something positive like this, then these treatments can be offered. And this targeted therapy again mainly attacks on the cancer cells and avoid toxicity to rest of the body. And so these are well tolerated, and it benefits in the sense patient can uh, we can downstage the tumor, the surgery becomes the prognosis becomes better, and the patients in stage 4 also, these treatments, these anti-cancer treatments can help patient live longer and control the disease for many years also. And then we have immunotherapy agents, which are available for last few years. And these basically work along with body's immunity and make cancer cells more susceptible to body's immunity cells. And so immunotherapy drugs are mainly used in very specific circumstances, especially where these receptors are not positive. So where we don't get hormone receptor positive, HER receptor is also negative, then there is role of using these drugs more. And they can also help in controlling the disease as well as sometimes totally eliminating the disease. And these patients can also live much longer as compared to when we were using only chemotherapy. And beyond this, we have certain agents where like in where we have this hereditary breast cancer, again triple negative breast cancer, BRCA positive breast cancer. So there are some oral targeted drugs available for these patients also, and they also improve the prognosis of these patients. So we have varied kind of these agents available, but we have to decide what agent to be used in which scenario, and that's a complex decision making depending upon patient's parameters.
Thank you. I think that was very comprehensive. And thank you. I will request Dr. Devavrat to just. So there's a lot of myth, or rather, a lot of fear related to chemotherapy for breast cancer, for that matter, chemotherapy in general. So it starts from how you select your drugs, duration of therapy, short dose dense, or 3 weekly or weekly chemos. So how you go through this process of decision making, how you select your patients, number one, and number two, the common side effects, including hair loss and loss of blood counts. So how do you manage this, and what is the plan? How the world has changed in last 10 years on these two fronts? The two components, one is how do you plan the treatment, select your drugs and the cycle and all that, and second component is the common side effects and what has changed in last 10 years.
Okay, I'm sorry, sir. I think the signal broke in between. So
Oh, you were audible?
yeah. So yeah, audible now. So I think question number one was, how do we decide, right? Did I get that correct?
Yes.
Okay.
Including
So I think
cycles, duration, all those things. Yes.
Okay. So I think increasingly the field is moving from one size fits all approach, where all patients with breast cancers would be offered similar drugs, similar regimens, similar duration. We are moving towards more personalized therapy, more if I can say it, more precision oncology. And therefore, if I have a patient who comes to me for chemotherapy or any form of systemic therapy, I ask a few questions. I look at the stage of the disease and try and understand the estimated recurrence rate for an early stage disease, or an estimated aggressiveness and overall survival for an advanced stage disease. I look at the patient, his or her fitness for therapy, presence or absence of other illnesses like diabetes, hypertension, how they could potentially impact treatment, and in turn, how my treatment can potentially impact those comorbidities and affect day-to-day living. Importantly, it's very important for the treating doctor to understand the biology of the disease, the aggressiveness, and last but not the least, the patient's wishes and the patient's goals in terms of quality of life are also important. For the higher stage disease, for the more aggressive disease, typically where we in a limited stage disease where a successful surgery has happened, we look at a higher possibility of recurrence. The field has moved towards more escalation of therapy. For example, for a HER2 positive case, one would look at 6 to 8 cycles of chemotherapy and up to a year of anti-HER2 targeted therapy. Similarly, for a triple negative breast cancer, one would want to add drugs like platinum, etc., into the treatment plan, which includes other standard chemotherapies as well. And similarly, for the early stage ER/PR positive HER2 negative, especially for those who present with early, very early stage disease like stage 1 and 2 or limited involvement of nodes, one is looking at de-escalation of therapy, where instead of offering chemotherapy to all these patients, would often look at the individual tumor grading, tumor size, etc. And oftentimes these patients would be candidates for certain specialized tests called gene expression profiling, which actually help us estimate the possibility of the true possibility of recurrence. In fact, enable us to avoid chemotherapy and as many as 80% of these patients with early stage disease. So I think that individualization of therapy, that personalization of therapy is increasingly happening, and I think that's making a huge difference to not only the outcomes but also the possible avoidance of possible long term effects of treatment.
About side effects, yeah,
Yes,
hair
so
loss. Are we doing something? Cool caps and things like that, or blood counts?
yeah,
One of the fears
I
in everybody's mind is infection, getting infection after chemo. Yeah.
right. I think the field has certainly moved some distance in terms of effectiveness of therapy, but I believe there have been even greater advances in terms of supportive care. So we all know that chemotherapy, with its inherent aggressiveness, will cause side effects. Chemotherapy will, usually also damage some of the fast-growing cells, which include our hair, which include our blood cells, and invariably a lot of patients who earlier used to have chemotherapy would have hair loss, would have significant nausea and vomiting, would have fall in their blood counts, including white blood cells, which are very crucial for fighting infections, fall in platelets, hemoglobin, etc. And those were challenging side effects, and those were actually also mean that in certain vulnerable patients, including the older patients, the more frail patients, because of those side effects, we would not be able to do chemotherapy, or we need to do chemotherapy at slightly lower doses, less than the desirable doses. Now, what has changed in the past few years? I think we have now newer and newer drugs to prevent nausea and vomiting. And I think when we talk about breast cancer chemotherapy, vomiting these days because of chemotherapy is a rare event. A lot of women still continue to have nausea, but not vomiting is very rare. In fact, I think that's one of the tremendous advances that the field has been able to achieve. That such a so vomiting may not sound a big side effect, but vomiting does affect quality of life, does affect oral intake of the patient, will lead to weakness, and we've been able to avoid that. Similarly, the other crucial side effect is the fall in white blood cell counts, leading to fall in immunity, which would mean that these often in the earlier days, this would mean that the patient would be advised isolation, advised not to go out, to stop working. But now we have safer drugs, which are less myelosuppressive. We have things like growth factor injections, which ensure that once they are administered post the chemotherapy, the white blood cell counts are maintained at optimal levels, which ensures that patients do not need to isolate themselves. They're not significantly at higher risk. There is certainly a slightly higher risk of infection, but that risk is not significantly higher. And in fact, a lot of our patients not only go out into the communities, actually continue to work while on chemotherapy. Similarly, hair loss has been a huge, huge worrisome side effect for most women. Nobody likes to lose their hair, and for a lot of women who come to me with a curable cancer, the worry is how frequently does hair loss happen? When is it like to happen? Now, we have devices like cool caps. So these are simply machines that a patient applies to her head prior to chemotherapy. The device cools down the scalp, ensures that the chemo delivery is limited to the scalp. Therefore, the hair follicle damage is limited, and therefore, for select patients on certain select regimens, the device ensures that the possibility of hair loss is lower. The hair loss is not as comprehensive. In fact, a lot of these women would still have some thinning of the hair, but there's no bald patches, no hair loss. And cool cap is something that we used in the past, and we are going to start using again soon. And I think cool cap also has taken away the risk of this very, very dreaded side effect, hair loss of chemotherapy. And I think these are the prominent changes, but there have been advances in in most possible areas where side effects are seen. because of
There's one
chemotherapy.
question from Rana Bhattacharya. If chemo is causing skin rash or skin allergies, should one stop chemo? What's your response to that, Dr. Devavrat?
So I think it's a good question, and I would expand it to all sort of side effects. So whenever we have a side effect, and including a skin related side effect, we do a medical grading of the side effect, where I would label it as a mild side effect, or a moderate, or in fact some side effects may be termed as severe side effects. Now, whenever I have a mild to moderate side effects, obviously as a doctor I would want to do all that I can to ensure that the side effects gets better, reduces to what is considered manageable before I restart chemotherapy. Typically, for the more serious side effects, one would certainly consider postponing the chemotherapy, and in certain cases reducing the dose of subsequent chemotherapy, in order to ensure that even if the side effect recurs, it doesn't recur with as much severity as it happened in the first time. There are obviously certain side effects which can be life threatening. For example, if one is talking about skin related side effect, things like Stevens-Johnson syndrome or TENS are very rare with chemotherapy. But if a patient were to develop a side effect like that, this would certainly mean that the doctor will have to replan the entire treatment and possibly stop treatment. But a minor side effect like a skin rash can be managed symptomatically, and would not, in most cases, would not necessitate dose reduction or stoppage of chemotherapy.
I have a couple of questions for Dr. Bhuvan now. So one is related to the role of hormone therapy. Is it always used in adjuvant setting, or you have something like neoadjuvant hormone therapy also? And plus also, how does fertility get affected by cancer treatment as a whole, including chemotherapy? And what are we doing to have a woman's chance of fertility being available even after the treatment is over? So I want you to cover two aspects. One is the hormone therapy part, the neoadjuvant, anti-adjuvant, and the second is the fertility-related issues related to breast cancer.
So I think both are very pertinent questions. So I think both of Dr. Arya also said, and we have heard in the past, that we generally divide breast cancers into three broad topics. One is hormone positive, one is HER2 positive, and one is triple negative. So what we need to understand is majority of the breast cancer, up to 75% of them, are hormone positive breast cancer, and this is the most common breast cancer which one comes across. Now the thing is, in the most of the hormone positive, or almost everybody in the hormone positive cancer group, it ends up receiving some degree of hormone therapy once the intensive part of the treatment is over. Once the surgery is done, and if the chemotherapy is required, that is done, and once the radiotherapy required is that is done, you would be, or any patient is generally put on one pill a day hormone therapy, which generally goes on from anywhere between 5 to 10 years. This is done to prevent the late recurrences which tend to happen in a hormone positive breast cancer. Now, this is a very easy therapy to take. However, it has its own certain side effects, such as body ache, such as joint pains. There is some degree, it can happen that may have some degree of mood changes, muscle aches can happen, and that there's a lot of education and there's a lot of counseling which is done before any such therapy is started. So this part of hormone therapy, which is given after the intensive phase of the treatment, is called as an adjuvant hormone therapy. That means it is being given as an adjunct center of the basic surgery and the major intensive therapy. Now, if the similar hormone therapy is done before the surgery, it is called as a neoadjuvant hormone therapy. Now, the point arises is, where do you do it and why do you do it? So let's say somebody has a slightly bigger tumor, which is hormone positive. So we're obviously talking about hormone positive cancers here. So somebody has a slightly biggish tumor. The patient is not being able to operate up. As a surgeon, when we have a discussion in our tumor boards, we feel that it is not a good case to be operated upfront. We may choose to give you hormone therapy before the surgery. Let's say a patient doesn't want a surgery upfront. They have some commitments to be given about. There are issues which cannot be pushed at as yet. So obviously life is important, but then there are certain issues which are also important, and we are unable to operate upfront. If we end up giving this hormone therapy before the surgery or before the central treatment, we will call it as a neoadjuvant. It's the intent which changes. Now, what a thing needs to be understood here is, generally the duration of neoadjuvant therapy is usually somewhere between 4 and 6 months. We should not go beyond 6 months, because the best time to achieve that response generally happens by 6 months, and disease tends to progress after 6 months. So that's how we define the two intents of therapy. Now, coming to the types of hormone therapy, it's depends upon whether, as a woman, we are talking about a premenopausal woman or a postmenopausal woman. So it's very important. So whenever somebody has a breast cancer, the first thing possibly I ask to a woman who comes to my clinic is whether are you have menses ongoing, and do you want children or not. I think with the younger and younger women coming up, these are the two most important questions which I ask. The reason we ask these questions is because we want to know what is the functional status of your ovaries. That will determine for me the type of disease you have, the aggressiveness, and the type of hormone therapy. Now, coming to the second question of the oncofertility or the fertility preservation. So in our clinics, what we are seeing is a lot of younger women are coming to us for chemotherapy or for treatment of breast cancers. Now, once you have completed your family, the decision that you may not be able to have any more children is an easy decision. You possibly are not bothered about it because you have completed your family. But as we are seeing a lot of younger women coming to us, there is the first discussion we end up having moment we say chemotherapy is whether do they want more children or whether have the family completed or not. So now, what is the first question which generally gets asked is, doctor, what is my risk of infertility with the chemotherapy? Now, please understand, it's a very individual decision. The number of eggs a female is born with is at the beginning, and once you have an onset of periods, you start losing eggs, and that's not an unlimited. You generally finish those eggs by the age 47, 48 happens. If somebody is less than 30 years of age, and if I'm giving them chemotherapy, there's a good chance you will have some degree of fertility preservation or fertility present at the end of chemotherapy. But as you go beyond 30, the moment you start touching 40s, your egg reserve tends to diminish. And there is a real chance that if I give you chemotherapy, you will probably have some degree of infertility. I'm not saying that you will become postmenopausal. You may still have periods ongoing. You may still have menstruation, but you may not be able to bear a baby. That's because your fertile eggs have been depleted because of the chemotherapy. Now, what do you do to prevent that? Well, there is it's easy. If you have a partner, if you are married, the first thing which we tend to do is we ask and we counsel the couple, because if you want a baby, the best thing is to go for oocyte preservation, and then a better is embryo preservation. That we stimulate the lady, we tend to take out the oocytes, and we kind of fertile them and make them an embryo and then store them away. That's the first and that's the most robust method of preserving the fertility. Then you'll be able to use that embryo later on. At times, it does happen that the female doesn't have a partner. In that case, what we do is we generally simply stimulate the female. So all this happens under the guidance of an infertility specialist. It's obviously being infertility expert. It's a broad outline which I'm giving you, but then this is the way it generally is approached. So if your female doesn't have a partner, there are still options available, and you simply go for a oocyte preservation. In some cases, because this requires a certain degree of time, in some cases, if you do not have time, let's say somebody has an aggressive tumor, I do not have 2 to 3 weeks for this thing to come. What we do is we generally suppress the ovaries by a GnRH analog, by a injection to your body, which is given once a month and started somewhere 3 to 4 days before you take chemotherapy. So anybody who wishes to preserve fertility but doesn't have the time for a oocyte preservation, we generally tend to give one injection 3 to 4 days or a week before chemotherapy. which suppresses the ovaries and if prevents them from the harmful effects of chemotherapy. So this, if this helps you in preventing the fertility, and let's say you have a 20% risk of preserving, the chance you'll preserve your fertility, this doubles to 40% if I give you that injection. So it doubles your chances of preserving fertility. That's where it is. So these are the three
Perfect.
most common.
If I may put all this together and say that every woman has a right to ask about the chances of fertility and who is the oncofertility expert in the team, so that we are all collectively delivering the best possible for each person, because then the fine tuning happens thereafter. Will that be a fair thing to say, Dr. Bhuvan?
I think you have put it just the right. I think the message is the conversation has to happen. Without the
That's
conversation, so I think all of us have this habit of encouraging the discussion in our clinics, because without the discussion, we'll reach nowhere.
I will respond to one question on the screen and then I'll ask Dr. Sachin for his comments and then we'll take one question. So one question on the screen is there. One lady has came to me for uncommon request. She was a sportswoman and wanted to go for mastectomy, willingly to prevent chances of breast cancer, though there was no evidence of family history. How much scientific is this approach? So in a general way, I would say for a person's health, whether it's a cosmetic surgery, whether it is an elective surgery or quality of life surgery, likewise, even though there is no identifiable risk factor, if somebody wants to go for it, there should be a proper process of information sharing, consenting, and then that is the person's choice. I don't think we as medical professionals can decide that this cannot be done. This has to be done if the person wants, and that has to be done through proper information, proper consenting and understanding that there's no risk factor, we don't know where it is, and however, if the person wants, one can go for it. Any difference of opinion on this reaction, Dr. Devavrat or Sachin or anybody for that matter?
Yeah. So this is although it needs to be discussed in detail with this particular patient, that what is her idea of where from she got this idea of getting mastectomy done. So we need to find out the actual reason, because if it is just fear of getting any kind of cancer, especially breast cancer, then there are so many other organs in the body. You can't just take out everything. So it's not a very, doesn't sound like a great
So
idea.
basically, a conversation has to happen.
Yeah.
However, the person after the end of all that wants to go for it, I think it's a matter of choice also.
Yeah.
We cannot stop that. People go for cosmetic surgeries also, and which is very much an unindicated, one can think, but it's one's concern for their own body. So that can go on. So, Dr. Sachin, there was a couple of questions on the screen which I did not say because they were all coming towards the end. Is breast cancer curable or is it fatal? That came in two question forms at different
Yeah.
points.
So
How will you
again,
summarize that?
yes. So breast cancer is by and large curable, especially if detected early. So all cancers, and especially breast cancer in early stages, most of these cancers are curable, and these women can lead their normal lives after treatment, after getting their surgery, whether it is a conservative surgery or mastectomy, and whatever chemotherapy or therapy has been used. But in late stages, and especially if it is stage 4 and metastatic already, so we can't technically call it a cure, but these patients also live longer, and so they can get life of many years with treatment. And of course, treatment continues, and they may suffer from multiple relapses, and multiple time treatment may have to be done. So the message is that in early stages, by and large, curable. In stage 3, again, the chances of the risk of recurrences are higher, but these patients can also be cured. But stage 4 patients, we don't call them technically cured, but we can control the disease with treatment and help these patients have a better quality of life and live longer.
Thank you, Dr. Sachin. I think your signal has gone down. Any parting thoughts, something we have not missed, not discussed, Dr. Devavrat, Dr. Aditi, Dr. Bhuvan? Anything you want to? Dr. Devavrat, first your turn. Any
Yeah.
parting thoughts? Yeah.
So I think 2 or 3 parting thoughts. One, adoption of a good, healthy lifestyle, modifying preventable risk factors and reducing the risk of this disease. Number 2, I think even if there are no symptoms for the appropriate age patients, A screening mammography is a simple test and picks up cancers very early, ensures that most of these patients are cured. And number three, if somebody does have symptoms like a breast lump, nipple discharge, change in the shape of the breast, or nipple retraction, or lump in the armpit, etc., it's very crucial that they go to a doctor, get themselves evaluated. Do not worry about FNAC or biopsy. Undergo a biopsy without there being any fear of spread of the disease, and do the appropriate imaging testing, because a timely intervention, cancer will not grow over years. Most breast cancers, especially the more aggressive triple negative ones, actually grow over months, and therefore will increase in stage if they go unchecked, untested. So if one has a symptom, please seek medical help very early.
Dr. Bhuvan, your thoughts? Anything you want to say?
So I just have one. I think we've had a very comprehensive discussion. I just want to say one thing. No age is young to have a breast cancer. Generally, we all have seen that, we generally, a younger female generally feels I can't have a breast cancer, and probably they end up having a locally advanced disease. And rather, the proportion of our locally advanced disease is more in younger because they had this thing, I'm too young to have a breast cancer. And rather, I personally have experienced females who felt that, this lump cannot be cancer because I'm too young. So just believe that no age is too young to have a breast cancer. It's important to have a discussion. It's important to get every lump evaluated. Go to a doctor whom you trust, and eventually end up having a examination done as a triple assessment, which we said earlier should be done. That's about it.
Thank you. Dr. Aditi, any parting thoughts you want to say?
No, I think Dr. Devavrat and Dr. Bhuvan summarized it quite well. It's basically the three things: breast self-examination for all
I
women.
think we have had a very
Screening.
comprehensive conversation in the last 1 hour, and it has covered most of the aspects. But obviously, there's much more we can talk if we go into more detail and further this thing. But today we can say that breast cancer is highly curable. It is possible to prevent a good chunk. 15-20% can be prevented just by lifestyle improvement. And almost 75-80% can be diagnosed early. And so we can save so many more lives just by spreading awareness and improving our lifestyle and other factors. So with that, I want to thank VOH and I want to thank Cipla for organizing this. And thank you all. Thank you.